As we learned in the Introduction to Health Assessment, there are a number of different types of databases that we can gather data for. In a complete database, we need a complete health history. This isn't often done in the 2020s. In theory, it should be used when someone is admitted to the hospital, when someone meets a primary care clinician for the first time to set up primary care, or when someone is starting prenatal care. A complete health history is indicated at that point. It often doesn't happen to be absolutely complete. However, it's really good skill to have. If you learn all the broad categories of everything that goes into a complete health assessment, you'll be able to pick out the pieces that you need that are appropriate for that patient in that situation. So fairly obvious, we're going to gather some demographic information. Two things on this list that may not be self-evident are source and reliability and reason-seeking care. Source refers to who is the person that's giving the information. Usually it's the patient themselves, but not always. What if the patient is 12 months old? It's probably a parent or a caregiver who's the source for that information. Or maybe someone is unconscious, and so you're talking to somebody else gathering information. And that would need to be reported and documented there. If you're using a medical interpreter to interpret to another language, it would be important to document that there. Reliability refers to the ability of this reporter, usually the patient, to give good information. So what do I mean by good information? Information that is answers to the questions you're really asking, as opposed to tangential information that's sort of off to the side. Or sometimes you'll have a patient whose story changes throughout the interview, or a patient who won't get specific as much as you try. How long have you had this symptom? Oh, for a while. Well, what do you mean by a while? It's been some time now. Instead of giving you a number of days or weeks or months, you can't quite pin them down. That would be called a vague historian. Or if someone who is confused, maybe someone has dementia or delirium, they might be referred to as a confused historian. Someone might be referred to as a clear historian, a good historian, a complete historian. So that those would be ways that you can refer to reliability. Reason-seeking care means, why are they being interviewed by a nurse at the moment? Why are they in hospital? Why are they presenting at clinic? Why are they in the emergency room? Whatever the case is. DOS means date of service. DOB means date of birth. HPI stands for History of Present Illness. And this refers to all the details having to do with the reason the person is seeking care. So for instance, if they're having a particular symptom, we're going to do what's called a symptom analysis. And you're going to talk more about the details of a symptom analysis in the pain module. Sometimes a presenting illness is referred to as a chief complaint, or CC. This is a little bit of an old term, and it's fallen out of fashion, perhaps for a good reason. Complaint kind of makes it sound like the patient is whining or something, as if they don't have the right to talk about that problem. So you may hear chief complaint, or HPI means an analysis, lots of details of what their main concern is. There are different ways of getting a symptom analysis. One may be OPQRST method. Another method can be using the old CARTS mnemonic. But we want certain information, including when this symptom or problem started, if they've had it before, where in their body they're experiencing it, the severity of this symptom or problem, what makes it worse, what makes it better, if there are associated symptoms with this problem, what effect does it have on their activities of daily living, and what's the patient's perception of why this illness, sickness, or symptom is happening to them. That can sometimes be very useful. What's an ADL? ADL stands for Activities of Daily Living. There are certain activities of daily living that are common for all humans. Okay, we all have to be able to eat, feed ourselves. We have to be able to sleep. We have to be able to ambulate. Ambulate technically means walking, but however that person mobilizes and gets around in their world, whether it's using a wheelchair, a scooter, crutches, a walker, that's all ambulation. So how does this person get around in the world? That's an activity of daily living. Everyone needs to be able to groom themselves, toilet themselves, dress themselves, wash themselves. Those are a common denominator activities of daily living for all of us. Now, on top of that, we have ADLs that are specific for our particular circumstances. So, for instance, you need to be able to concentrate, sit for a certain amount of time. When you're a nurse, you need to be able to walk, you need to be able to lift, you need to be able to write, you need to be able to use computers. Those are ADLs. Someone who works construction, their ADLs may involve much more physical, demanding things how you get to work, whether that's being able to drive a car or being able to use a bicycle or being able to walk or being able to take the subway. Those are ADLs. If I live in an apartment on the third floor, I need to be able to walk upstairs and walk down. Those are ADLs. The extent to which a patient's illness, disease, or symptom is inhibiting their ability to get their ADLs done, this is a really helpful way of quantifying how severe that symptom and disease is, but also it really helps us understand how we can think about ways to help our patients. PMHX means past medical history. We want to know what kinds of diseases and illnesses this patient has had. Especially, we want to think about the serious and the chronic. So serious are things like a heart attack or a cancer or a pneumonia. Chronic things like diabetes or asthma or congestive heart failure, hyperthyroidism. But we want to have all that information because what's happening with the patient now might be related to that disease, and or that disease may impact how we choose to treat or how that person experiences the treatment. Make sure you note if your patient has arthritis, hypertension, thyroid issues, kidney issues, liver issues, if they've ever had cancer, if they've ever had heart disease, if they've ever had respiratory disease. These are the biggies. They're really important to capture those. If there's a very complete health history, you want to get everything, but you especially have to get those serious diagnoses. Past surgical history is also important to collect. PSHX. If someone has had a surgery, we want to know what kind of surgery and also what date that surgery happened. So the year if it's been a long time, or if it's more recently, a month or even a day if that's appropriate. If someone had a hysterectomy 3 days ago, it's a very different piece of information than if they had a hysterectomy 20 years ago. How did this person perceive their health? Do they see themselves as having good health, ailing? Do they think they're dying? Are they having trouble taking care of themselves? What major childhood illnesses did this person have? What injuries have they had? Sometimes this falls under past medical history, but sometimes when you ask about past medical history, they're only thinking about diseases. So I want to make sure that you ask about injuries as well. So motor vehicle accidents, MVAs, or a sports injury, or any other kind of accident or injury needs to be noted. If any disease or accident is acute, you want to have the date, at least the year, listed there. If it's episodic, that's not as important if it's something that's chronic, like diabetes. What immunizations has your patient had and when? Have they had all the shots that are indicated for their age, developmental level, and occupational risks? When was the last time they had a physical exam? What medications are they taking? And we want to know not just what prescription medications they're taking, but also anything that they're taking over the counter, and also including vitamins and supplements or home remedies. These can have significant impact. They can have side effects, they can have interactions with other medications, so we want to make sure and include everything. What allergies does this person have? Specifically, we want to know about drug allergies. Sometimes food allergies become relevant too. For instance, eggs are sometimes used in making vaccines. So if they have a dangerous reaction to eggs, we would want to know that. Mostly we're concerned about drug allergies. And if someone says they have an allergy, we want to know exactly what their reaction is to that allergen. You know from pathophysiology that classically an allergy starts with a skin rash, hives, or urticaria. And then if it gets worse, it can result in swelling of the throat, tongue, the oral tissues, the face. That's called angioedema. And if it's even worse, the swelling in the throat can cause asphyxiation or death. That's anaphylaxis. This is extremely important to differentiate from I'm allergic to Benadryl because it makes me sleepy. Sometimes people say I'm allergic to some medication because they have a side effect that they don't like, or an unusual side effect, or their parent is allergic, so they figure that maybe they inherited that. It's important to document what their understanding is about their reaction to that medication or substance. If someone gets a queasy stomach when they take codeine, that's really important to know, and we want to try to avoid giving them codeine if we can. On the other hand, that's a very different reaction from something that's life-threatening. So as a nurse, you might make a different calculation based on knowing exactly what that reaction is. You don't have to tell them, if you get heartburn from ibuprofen, that's not an allergy. You and I know maybe that that's just a side effect, not an allergy, and we want to respect that in our patient, but it's helpful to differentiate. We want to gather a family history from our patient. Family can mean lots of different things: socially, psychologically, emotionally, genetically. In the case of a complete health history, the subsection of family history is going to include 3 things. Biological first-degree relatives. First degree means parents, siblings, children of the patient, even though we know that adopted parents, siblings, and children are just as important psychosocially, but there's a different consequence for the genetics of the patient. Another category that's going to be included included in gathering history about the family is any household contact. So, for instance, I may or may not be very close to a roommate emotionally. Maybe I'm not close at all emotionally to my roommate, but if he or she has tuberculosis or COVID-19, their health is very relevant to mine. So, we're going to consider that family history, even if household contact isn't family. And then there's a third category that we're going to include under family history. That's significant others. So if your patient has a spouse who lives elsewhere, a romantic partner, or maybe best friend who is living elsewhere, their health can still affect your patient. So for instance, if I have a spouse and they're in prison, do you think their health affects my health? Yeah. Even though I haven't seen them for so many months or years, still relevant. So we're going to have 3 subcategories under family history: biological first-degree relatives, household contacts, and significant others. Those are all going to be considered family for the purposes of family history. In terms of genetic concerns, we use the mnemonic BALD CHASM to think about particularly relevant diseases that can be inherited genetically. Thinking about social contacts or household contacts, infectious disease, alcoholism, violence, immunocompromise, those are things that are likely to affect our patient's health too. One way of documenting family medical history is called a genogram. Now, genograms are used in lots of different professions, not just nursing, but also psychology, education, literature, history, all sorts of different professions will use a genogram, and they all use some basic rules. It's a graph like this, where the older generations are higher on the graph and the younger generations are lower on the graph. There are some rules that we're going to use in a nursing genogram that you need to know. So an arrow points to the patient. The shape that has an arrow is the patient. Traditionally, circle means female and a square means male. There's not traditionally a shape for transgender or other gender or non-binary, but I'm sure that might be changing. For now, we just have those 2 shapes as far as I know. So if this is the patient, a lateral shape means a significant other. May or may not be a legal relationship, and the shapes below indicate children, usually but not always biological children. Ways that we indicate death, dying, having deceased include a slash through the shape, a small d, an arrow down, or shaded out. Those are all ways in which a shape or family member might be indicated as having died. In terms of a nursing genogram, A and W doesn't mean root beer, it means alive and well. Usually we'll put someone's age on their genogram and major diseases that that person has, that the patient knows of. Of course, their grandparent or their parent or sibling might have all kinds of other diseases that the patient doesn't know about, so we're only getting what they do know about, of course. That might be limited. Some families, they share that kind of information. Other families know very little about each other. But age that they are currently or age that they died would usually be noted, and major disease diagnoses, or if they've been very healthy, alive and well. ACEs refers to adverse childhood events. There was a landmark study in the 1990s that showed that traumatic events occurring before age 18 had a marked impact on an adult's physical and mental health. So adverse childhood experiences include things like abuse, neglect, or household dysfunction. Violence, incarceration, or substance use seems to be highly correlated with a variety of negative outcomes in adulthood, including poor physical and mental health, substance use, and risky behaviors. The more ACEs somebody experiences, the greater the risk for these outcomes. So it becomes really important data for us to gather that can speak to what our patient is at risk for. We want to collect gynecological history on all of our patients who are women or who have had female reproductive parts. So things like LMP, which stands for last menstrual period, and specifically LMP refers to the first date of the most recent bleed. So that might be a month ago, 10 years ago, it could be yesterday, it could be today. So if someone is currently on their menses, they started bleeding this morning, then their LMP is today's date. Or if they had menopause 10 years ago, of course you won't necessarily get it down to a day, a year is fine for that. If they're of childbearing age, being more specific is obviously more important because we need to know their risk for pregnancy as well as other things. Menarche is the age at which a person gets their first menstruation, so sort of 9 to 13, more or less. GNP stands for gravidipara. Gravida means the number of pregnancies that a person has ever had, including any current pregnancies. Para means the number of deliveries a patient has had. So that includes C-sections as well as vaginal birth, and it includes any pregnancy that's gone more than 20 weeks of gestation. Average human gestation is 40 weeks from LMP to delivery. So if you cut that in half, that's 20 weeks. So if someone loses a pregnancy, either terminates intentionally or miscarries a pregnancy before 20 weeks, that's not considered a para. If, however, they have a pregnancy after 20 weeks, whether it's a premature birth, stillbirth, anything that is after 20 weeks of gestation is considered a para for the sake of G's and P's. So you'll see capital G subset number, capital P subset number. So for instance, this person has had 5 pregnancies and 3 deliveries. TAB and SAB stand for therapeutic abortion and spontaneous abortion. Spontaneous abortion meaning miscarriage. Therapeutic abortion can refer to either medical or surgical induced abortion. They're both called abortion because physiologically it's really the same process. It's obviously probably a different experience emotionally for the patient. Physiologically, they're very similar. So sometimes it'll be GPTS or TAB-SAB. Now, G's and P's can get quite a bit more complicated if we start talking about twin pregnancies and children still living. I'm going to leave it to your maternity professor to start making that more complicated for you. For now, I want you to know G, P, T, and S and what those stand for. We want to know if this person has had a pap smear ever, what's the most recent one, if they've ever had a non-normal, if they've had a human papillomavirus vaccination series, if the series was full, if they finished it, because if they haven't, then we know that they could be at risk for genital warts and or cervical or uterine cancer. And we want to know their obstetrical history, just the simple version of obstetrical history, meaning what years they delivered, if those were vaginal cesarean deliveries, and did they have any major complications like a hemorrhage or eclampsia or an infection. We're also going to get a sexual history on our patient, and there'll be a longer module about this later on in the course. But for now, we'll ask our patient if they're sexually active, and make sure you try to use words that make sense to them. We want to make sure that they're not misinterpreting. If you ask a teenager if they're sexually active and they haven't had sex in 3 or 4 weeks, they may think that that's not active because it's been so long for that teenager. But it's very relevant in terms of their health history. So make sure that you're clear. We want to know if our patient has had or is having or is planning to have sex with men, women, or other genders. And sometimes we have to be pretty specific in what we're asking because someone might be at risk for pregnancy or in sexually transmitted infections depending on what behaviors they're doing. We know that sex encompasses a great deal more than penile-vaginal intercourse, and so make sure that you're asking what you need to know. Is this person using contraception? And contraception doesn't just mean the birth control pill. It means any kind of thing that keeps someone from becoming pregnant. So for instance, an IUD or a patch or condom use is a kind of contraception. Ask what they're using, if anything, if they're happy with that method. If they're not using it, maybe they're not at risk for pregnancy. Ask what their perception is of that, or if they're trying to get pregnant. Can't tell you how many patients I've had who thought they couldn't get pregnant and now suddenly they are pregnant and they weren't trying to get pregnant. But they weren't actively contracepting because for some reason they thought that they couldn't get pregnant because maybe they had sex a few times and didn't get pregnant, so they thought, it's not going to happen. Then they got careless. Ask them if they use condoms, if there is penis involved, and not just if they use condoms, but how often they use condoms. Because if I've had sex 10 times this month and I used condoms twice of those 10 times and you ask me if I use condoms, well, technically the answer is yes, but it's not all the information you need to know as my nurse. Besides the presenting symptom or problem that a patient has, we want to get something called a review of system, or ROS. Review of systems means that we're going to touch on each body system and try to make sure that if our patient is experiencing any other problems or symptoms, that they're letting us know about those too. They may or may not be relevant what's happening now, but they may very well have impact on how we treat what's happening or how we diagnose what's happening, and the patient may not make that connection because they're not a healthcare professional. Or even if they are a healthcare professional, they're sick. Don't make them think about it. That's for you to figure out. So a review of systems touches on general symptoms or constitutional symptoms, meaning fever, fatigue, problems sleeping, a significant weight change. We're going to ask if they've had any changes or problems with their skin, hair, or nails. in their head or neck, any lumps or bumps or new lesions, any problems with their eyes or vision, with their ears or hearing, nose, throat, problems swallowing, any changes in their breasts, in their breathing, any shortness of breath, any coughing, any chest pain. Think about the GI system, any nausea, vomiting, diarrhea, constipation, any belly pain, any pain anywhere, genitourinary area. Have they had any pain with sex? Have they had any pain with urination? Any problems with urination? Anything strange in their arms or legs? Stiffness, pain, weakness, numbness, dizziness, loss of consciousness. Loss of consciousness is abbreviated LOC. LOC can mean level of consciousness or loss of consciousness, depends on the context. We want to know a little bit about what they do. It tells us something about what they're at risk for and also what they might have expertise in. We want to know not just what they do for a living, but also how they recreate. So if this person is a skier or a quilter or a motorcyclist or a swimmer, that might put them at risk for different things. And also it speaks to certain strengths that they have. We want to know the last grade of school completed. That can really help us understand where to aim some of our explanations about health and illness, what language to adopt when we're speaking to them, thinking about the written materials that we give them or websites that we refer them to. It's going to make a big difference if they've only ever gotten through 8th grade versus if they have a PhD. Doesn't mean that they're not smart if they've only ever gotten through 8th grade, but it might indicate how they best digest information. Also, level of school tends to be very highly correlated to socioeconomic status, and it may tell us something about what means they have in taking care of themselves or mitigating risks. We want to ask about safety concerns at school or work, what they're exposed to, what methods of mitigating those risks they have. Are they given personal protective equipment for whatever their job is, whether it's healthcare or construction or teaching or anything, coaching, accounting. We'd like to know if they're in the military or if they've ever been in the military. We know that veteran status puts people at risk for certain diseases and conditions, and we want to make sure that we know what they might be at greater risk for. We're going to gather some data on their nutrition and activity levels. So in terms of activity, physical activity, we want to know if they exercise, but don't just say, do you exercise? Because some people think, well, if I don't go to the gym and do a certain Zumba class, that's not exercise. But maybe their job is that they're a mail carrier and they're walking 5 miles a day. Maybe they do exercise, but maybe they're doing all aerobic activity, or maybe they're not. Maybe they're doing slow yoga or slow weightlifting. And that whatever it is that they do, we want to know, we want to capture, but it tells us different things about what their body is used to. Besides the type of activity, we want to know the frequency, the duration, and the intensity of that physical activity. We want to know approximately how many hours of sleep they get each night, and if their hour of sleep, HS, is approximately the same each night, or if it varies a great deal. Or maybe it's not night at all, maybe it's daytime, maybe they work nights. And that's important to know. It has major consequences for health. So we want to know how many hours of sleep they get each 24-hour period, and then also the regularity of that sleep. And do they have trouble falling asleep? Do they have trouble staying asleep? Do they have nightmares? We want to get to their nutrition. You've had a whole course in nutrition, so I'm not going to spend a lot of time talking about it. In a complete health history, it's absolutely indicated, and for a lot of diseases, you're going to want to know about nutritive status. You can do a 24-hour recall. You can do a nutrition log. You can gather that information in different ways. It also can be a really useful way to gauge sort of how much education your patient has around nutrition and what nutrients they might be lacking and what nutrients they might be having too much of. Make sure you gather, if you haven't already, if they need any help with their ADLs, either from people or from mechanical assistance, like a walker or crutches or adaptive devices. We're going to talk more in depth later on in the semester about domestic violence, but for now, we'll talk a little bit about this in terms of complete health history. Who does the patient live with? Who are they in romantic relationships with? Have they had any problems with those relationships? Or do they feel respected? Do they feel safe? Have they ever been threatened or put down by their partner? Have they ever been physically or verbally assaulted by their partner? Are they afraid of anyone in their life? And it may not be their partner. It may be someone else in their family or a neighbor or someone at work. We want to try to get at that information too. What are this person's major life stressors? They might be at wit's end because they can't pay their rent and their grocery bills, or maybe their finances are fine, but their child just went to jail. Or maybe the biggest stressor in their life is that they have this cancer and they're worried they're going to die. Or maybe their biggest stressor is that they just got laid off, or they're having arguments with their teenage son or daughter. Is their housing, utilities, money, transportation adequate? Are they safe using those systems? Do they have what they need? Sometimes the best question to ask is, what's your biggest stressor in life? And you might get all sorts of new information that you didn't have before about what's really bothering them. Or besides this disease, what else might be going on in their lives? And what coping methods do they have? Does this person do well talking to friends? Do they go to church? Do they do yoga? Do they meditate? Do they like to do therapy shopping? What are the things that they do to help themselves? And are those coping methods compromised currently because of their illness or because of a pandemic or because of whatever reason? Are they not able to access those methods of coping? That puts them at greater risk and more vulnerability. What are their self-care practices? What are their religious practices? What are their spiritual needs? What supports and friends do they have? We want to talk about your patient's habit in terms of substances they might be using. So, for instance, when we look at alcohol use, there are different ways of doing a quick assessment or a more in-depth assessment to gauge how much alcohol they're ingesting and if that amount is creating a problem for them in their lives. The CAGE system is a really common short screening method shown here. If they answer yes to any of these questions, it doesn't necessarily mean that they're alcoholic, but it implies that there's a need for further assessment. In terms of tobacco, we want to know not only if they smoke now, but if they've ever smoked. And if they have ever smoked, we want to quantify that smoking. It turns out that the number of cigarettes that you've had in your life actually correlates fairly well with how much at risk you are for certain diseases and conditions. The longer it's been since a person has quit, the better off they are, certainly. But we also want to know approximately how much risk that their body has been under from tobacco. So the way that we quantify tobacco use is we look at how many years in their life they have smoked or they did smoke in the past, and we multiply that by the average number of packs per day that they've smoked. And if we multiply their packs per day times their years smoked, that's called a pack year. So if I started smoking when I was 20 and I stopped when I was 40 and I on average smoked 1 pack per day, that's 20 pack years. Now, it's important for those of you who don't smoke, and hopefully it's most all of you, for those of you who don't smoke, you need to know that there are 20 cigarettes in a pack, because one of your patients might say, oh, I smoke about 5 cigarettes a day or 10 cigarettes a day. So you need to be able to use fractions in that multiplication problem. So if I smoke half a pack a day or 10 cigarettes a day and I've smoked for 30 years, that gives me 15 pack years. And that puts me at a certain level of risk for tobacco-related disease. If someone is currently smoking, we want to assess their attitude towards quitting. Are they ready to quit? They don't want to talk about it. They've been trying and they've quit and restarted, quit and restarted, quit and restarted. That all really helps us understand approximately where we need to aim our teaching and coaching and supporting of quitting. We also want to know if this person has had significant secondhand exposure to smoking. We know, for instance, that children whose parents smoke are at higher risk for ear infections and asthma and other kinds of infections if their occupation brings them in close proximity to smokers or other secondhand exposures. We want to know if our patient vapes as well. We know that vaping puts our patients at risk for certain diseases and illnesses that can be quite serious and even deadly. So if you just ask about smoking, they might not include that unless you specify. We want to know about other drug use, whether it's cocaine or meth or ec or heroin. We want to know approximately how much they do, how frequently, and how long of their life they've been using that drug, or they did use it in the past. You might think this is a difficult thing to talk about, as long as you remember that your concern is with their well-being and are careful not to be judgmental and not to show any judgment on your face or your tone of voice. Make sure in every moment you're thinking about their wellness and respect them as an individual, knowing that there are reasons that they've made the decisions that they've made. They'll most likely answer you with respect and understand that you're concerned about them. Sometimes people will feel ashamed of having used the substances that they've used. I find as a nurse that as long as I'm making sure that my message is for respect for them, and then I would not blame them for making decisions that they've made. We all make decisions for reasons that have logic. They tend to really appreciate being treated respectfully. We also want to know what dangers our patient might be in because of particular lifestyle choices that they make. For instance, if they use a motorcycle or a skateboard, do they use a helmet? Are they skiers or race car drivers or rock climbers? If they do those things, what safety equipment do they use? How well are they trained on it? Do they use it regularly? Are they using seatbelts? Are they using helmets? If they're outside a lot, are they using sunblock? And at the end of this very long conversation, which isn't really a conversation so much as an interrogation, because who's asking all the questions and who's having to do all the answering is kind of one-sided. So we want to make sure that we make some time at the end of that conversation for the patient to ask questions and tell us what we might have missed, because maybe we didn't ask the thing that they were waiting for us to ask, or we didn't ask in such a way that we got the information we really needed to. So make sure that you ask some open-ended questions like, what are your major concerns today? Or what should I know about you that I didn't ask? Or what did I forget to ask? Ask them what their goals are for their health and for their visit. Or what have we not yet talked about that you want me to know about you? And then before you leave, Make sure you let them know what's happening next in their healthcare visit. Maybe you've just spent half an hour asking them all sorts of intimate questions, and now you're racing out of the room and they don't know what's happening with that information. Let them know what's happening next, what they can expect, if it's 5 minutes or 5 hours till the next person comes in to see them, or if you're consulting with someone else on their healthcare team, what kinds of things are happening. Make sure they get to ask you questions. And don't forget what a privilege it is to be asking all these intimate questions about someone's life, how much they're sharing and giving to you, and how much we owe our patients in terms of trust and professionalism.